Okay.
Yeah.
Hi, everyone. And so we're just rolling right through these talks because I think it's really important to have questions at the end. Questions are really important to you, and really why we're here is to help you. So that's why I think that we need to move on to questions relatively quickly. Okay, wait, do we want to restart me? Because I will just keep yammering on for as long as you allow me to, so I only want to give myself 10 minutes. Okay, so fun with fractional. The reason why we're all here is because 20 or so years ago, the Fractional was developed. And oh, by the way, I didn't realize that this was non-CME, so I'm just going to be rolling right along with, now I can say brand names. 20 years ago, there was a huge shift in what we did. And for those of you who weren't here 20 years ago, I can't begin to tell you how dramatically that changed everything that we were doing in dermatologic laser surgery. So it's amazing how far it's come. Here are my disclosures. I am either a consultant or sit on the advisory board of the following companies. It really only matters with Althera and Softwave because those are the devices we're going to be talking about. So going back to fractional ultrasound, if you think about it, again, everything is fractional now because of the way the skin heals. So fractional, microfocused ultrasound was first introduced back in 2010. Murad Alam was one of the first who published on the procedure and showed, the first study showed 30 or 35 patients got a significant brow lift. So we know that we can use these devices for lift, for skin tightening. There's no epidermal change. It goes through the surface of the skin. The way in which these treatments work with the microfocused ultrasound, depending on your the transducer that you choose to use, you can either go 4.5 millimeters into the skin, 3 millimeters into the skin, or 1.5 millimeters into the skin, depending on your transducer. And you deliver these little, they almost look like little rice-sized oblong zones of thermal injury throughout your specified layer within the skin, depending on the transducer that you use. And we have that healthy intervening tissue between those zones of thermal coagulation. So all of these years later, there have been many papers written on microfocused ultrasound and its efficacy and safety. I would encourage anyone who wants to see the whole background of microfocused ultrasound to look at Sabrina Fabi's paper and her colleagues. Mitch Goldman does a lot of work, obviously, with Sabrina. In Drugs and Dermatology, they did a beautiful review of all the different papers that have been written about this particular device. There are many indications in which we can use the device. These are both on and off label. I think the most, at least in my hands, the most common areas that we treat are the mandible, jaws, cheek, jowls and cheek, neck and brow lift. I find, once you go quote unquote off-road, once I go off face and neck, things get a little bit less predictable. The décolletage is another area that has been written about. Again, Sabrina has done quite a bit of work here. Upper arms, abdomen, legs. I have my little meh sign there because I think that the results can be quite meh. Depending on the patient that you treat. And you have to tell the patient very specifically. I tell them flat out, quite frankly, I might not be able to give you any result at all, so perhaps we treat a test area to see if you want to go ahead and treat the whole entire area. Patient selection is absolutely critical for success. These are relatively easy treatments to deliver. There's no epidermal injury, so you don't have to worry about post-op care for the most part. But again, the first step toward a successful treatment for lifting and tightening is picking the correct patients. And again, some areas, face and neck, respond better, in my opinion, than others. And we also prepare patients for more than one treatment for the best response. And there's going to be maintenance. Aging is not a one-time treatment, unlike when we're treating acne scars. Acne scars, I actually don't treat acne scars with these devices, but it just in general, when we talk about acne scars, that's a set number of treatments, whereas aging is not. You're going to keep aging if you're lucky, and therefore we're going to be talking about maintenance treatments. And I combine with other treatments. I think that's a very common theme you're going to hear from basically everybody here on the panel. So these are, I think, classic result that you can expect to get with, this is a patient who had 2 microfocus ultrasound treatments. For those of you who don't realize, this is the Althera treatment. And I think that these are very reasonable. This is a patient who could get a better result with an S-lift or a lower facelift, but she does not want one. So, or some of my patients will say, I'll do that, but not now. So sometimes we also do this as a stopgap measure until they're going to have a surgical procedure. This is 9 months after a single treatment. This patient actually did really quite well. 9 months after 2 treatments. I like to tell my patients to plan on doing their second treatment about 2 to 3 months apart. There's some debate about this. We learned from Rox Anderson a while ago that new collagen responds better to heat tightening than old collagen. So that's how I present it to my patients. So I tell them we're going to do our first treatment to quote unquote prime the pump. And then I'm going to have you come back 2 to 3 months later and we're going to do it again because all that new collagen will be set in there. Now, if you go back to the original laser papers, neocollagenesis can continue for 3, 6, even sometimes 12 months in some of those papers. So there has to be a time in which, that makes sense to do a second go around. We've kind of settled on 2 to 3 months. Some of my colleagues will say 6 weeks. They'll have them come back and do back to back. To get even, in their mind, they're getting better results that way. I usually tell my patients 2 to 3 months. Here, I circled the area because basically what we're doing here is we're trying to treat those deep wrinkles on the chest. They're difficult. These are difficult wrinkles. And Sabrina Fabi has shown that you can get some improvement with this device. I do find that it's a little unpredictable for that area. Some people do well, some people don't, and I almost always combine it with something on the surface, in this case, a broadband light treatment for discoloration. So, more recently, another device has been developed, ultrasound, synchronous ultrasound, parallel beam technology. That's the soft wave device. I'm just going to be calling it parallel beam ultrasound to make it easier on myself. This is the so-called Superb technology, and it has FDA clearance as of 2019. And it also has multiple on and off-label uses. It typically, again, same areas, face, jowls, neck. I think brow lift does a really nice job. It also has clearance more recently for cellulite and acne scar. I have no experience with acne scars. That'll be interesting. This is a device that treats at the 15, it treats at 1.5 millimeters within the skin. So since other devices that we know have efficacy for scars, as in the 1550 Fractional, perhaps it does, but I personally think you may need some epidermal change, epidermal treatment at the same time for acne scars. Again, my number one is an RF microneedling for that. So what's the difference between the two? Microfocus ultrasound, as we said, has a coagulation pattern. It puts these very specific zones of thermal injury at 1.53 and 4.5 millimeters within the skin. Each treatment is performed as a separate treatment pass, and they have the deep sea technology where you can see the area that you're just about to treat, which can be helpful, particularly if you're going to be treating very deep within the skin, so you know you are delivering the energy where you think you are delivering the energy. As compared to the Superb technology, which delivers these cylindrical, they look like little cables underneath the skin, only at 1.5 millimeters within the skin. So you've taken your fractionated treatment and you put it on its side. And you can get a very high volume coverage at the 1.5 millimeter depth by doing so. First pass, roughly, you'll get a 28% coverage with the first with 2 passes and a 42% coverage of that area with 3 passes. And there's no need for real-time visualization because you know you're in the dermis. So you're not concerned about potentially nerve injury, or you're going into the fat because you really don't want to be treating and putting heat into fat because we know it can potentially cause fat atrophy over time. So I treat the same area on the neck, 3 months after parallel beam 1 treatment, and I think these are reasonable. I try not to put in my very best photos, except one. I put in one here in a second. But I think these are reasonable. I think that these are to be expected for patients. Certainly this is not a facelift. If they're looking for a facelift, I refer people to my plastic surgery colleagues all the time. But these are patients who understand that they should get results that they can see, that they can feel, but it is certainly not a facelift. This is a patient who is 6 months after 2 treatments, and she's happy. What I really like this device for personally also is the little brow lift that you can get. This particular device has a smaller handpiece to treat the eye area, which is really quite lovely. And again, this is not a blepharoplasty, but it does show nice improvement. And this is kind of across the board. So this patient is 6 months after 2 parallel beam ultrasound. And I like it for that purpose very, very much. Knees, anyone who's tried to treat a knee knows that, you know, the knees may be my version of melasma for Paul. We get a lot of people coming in, okay, you've made my face and my neck and my chest look really good, but now what can you do for my knees? And I just kind of sink. I sink in my chair because there's not, you know, there are things that we can do, but they are really not predictable. I mean, when you see there's things you can inject, there's treatments you can do, there's all these things you can do for a knee, but that doesn't mean you're going to get a good response. I tell patients flat out, you may not see anything at all. This is a patient who did. She had 2 treatments. I think really importantly, when you're talking about doing treatments like this, or any, oh, this is my super great photo, by the way. When you're talking about doing any of these treatments, it's very, very important. It's imperative to deliver enough pulses in the area. We talked a little bit about that earlier on, you know, the treatment coverage and number of pulses that you put in an area, done in a safe way, obviously, is really critical to the overall outcome at the end of the day. Here's a patient. I try to treat this little crepey skin, and some patients get a result, some patients don't. This patient's first baseline photo, she's a little internally rotated, so I think she looks falsely terrible there, and then she's a little externally rotated on the outside on the second photo, but she did get some improvement. I can tell you for every 2 of these, I get 8 that don't. So you can try it, but just warn your patient that it might not give them what they want. So pearls for success, we've been kind of talking about this a little bit, realistic expectations. They have to know that this is not a lifting procedure at all. Prepare patients for multiple treatments. I flat out present it to patients now as a 2-treatment protocol. So we're going to do 1 treatment, then you're going to come back and you're going to do another. I think that makes more sense so patients know what to expect right up front, rather than saying 1 and let's see how you do, and then inevitably they'll come back for a second. I can't underscore how important good pain management is critical to delivering a thorough treatment, and that goes to the fact where you just need, you know, I don't deliver these treatments myself, my registered nurses do, and they need to be able to do their job. They know that at the end of the day, I'm going to be looking and signing off on, I want to see a high number. I want to see a high number of pulses that was delivered to this patient. And if they're squirming, if they're uncomfortable, you know that they're not going to get the treatment that they need. So don't be afraid to use some pain medication on patients. I know when some of these devices first came out, particularly the Softwave, they said, oh, you could just do it with Advil. Has anyone ever tried to do that treatment with Advil? I did, and I'm still cursing them to this day because it really is very uncomfortable. But with pain medication, it's great, and there's no recovery. So these are really nice treatments, but you have to deliver a lot of lines or pulses or whatever you want to call it. In my practice, for patients, we do anywhere between 50 and 75 milligrams of IM Demerol, along with 10 milligrams of 5 or 10 milligrams of Valium. I ask them flat out, how much do you drink? Because if they drink a lot, they get 75 and 10. If they drink little or they're teetotalers, which I have some of them, they get barely anything, because you have to be very careful with the teetotalers because they will get very, very sleepy on that regimen. Some practices do IM Toradol. I am not. I don't. I just find that the Demerol, I know exactly when it's going to onset. And you can use the combination nitrous oxide delivery system. That's the Pronox. I think that that's helpful too, but I don't think that's good enough. I think it's fine for if we're doing just a brow treatment or a periocular treatment to get like a brow lift, because topical anesthesia, 30% lidocaine, works really well around the eyes because of the absorption. But once you start going on the lower part of the face to try to get tightening, I think you need pain management. And when you have pain management, you can deliver the treatment that you need to do it, you can get the results you want. And since this is fun with Fractional, we are combining it with everything under the sun. So on the same day, we combine it with non-ablative fractional resurfacing. I love the 1927. I do a lot of it. You just have to tell the patients that they might have a little bit of extra swelling. Again, patients can get really nice results where they can get tightening of the skin and improvement of the texture and the tone of the skin as well. And here's a patient with the parallel beam technology. I also do quite a bit of this with cryolipolysis. They come and they get their cryolipolysis first in the submental area. It works like a dream, and then you can tighten them up a little bit too. I do not do this on the same day. I split that up. Great. So here is my email if you guys have any questions after this, and thank you. Thank you for listening. So now